certain limited entities like pneumonia. Hope my slide is visible too.
Yes, sir.
Please confirm whether it is changing.
Okay, sir.
Yeah. Okay. So once again, I wholeheartedly welcome all of you to this session regarding Jwaram. So even though my topic has been fixed towards certain limited entities like pneumonia, dengue fever, influenza, chikungunya, etc., I put this title, Jwaram, Fresh Perspectives for Current Era. Why? Because we are speaking about this topic particularly today or even in these coming days of COVID-19. I am speaking to you from Kerala, where still almost 100 to 120 persons die every day due to COVID-19. Even though the number of COVID-19 infections has came down recently in our state, still the number of people dying per day is crossing 100. For a small state like Kerala, with so many deaths happening in front of our eyes, we should have some fresh perspectives for current era management of Jwara. So, being this being the I think the first session of this Jwara series, I want to put forward certain initial introductory elements of Jwara into this presentation. So I welcome you everyone. Let's together discuss some very interesting facts regarding Jwaram. What the people expects from us Ayurvedis. What should be the futuristic concepts or futuristic steps which we have to adopt so that we can manage the upcoming fevers. Now we are in the grip of second wave. And there are predictions that there are future more waves are coming. And even though vaccination drive is going perfectly, the rate of infectivity cannot be cut down simply by giving some vaccinations. So the wisdom which is coming to us down from ages, centuries back, the interesting observations of learned clinicians who have recorded those observations in our prestigious Samhitas. We have to explore back, we have to go back, we have to see what our acharyas, what the master clinicians in India have done when they battled with the severe crippling fevers in the past. So I think Ayurveda is actually a recorded history of the disease pattern, the responses taken while diseases came up, how the epidemics were handled, how the persons were revived back into life. So all those recorded observations are hidden, lying in our Samhitas, and a lot of medications devoted for each spectrum of Jwaram is available there. So, the term Jwaro Rogapati is actually the introductory statement of Vagpada when he starts Ashtanga Hridayam Jwara Nidana. Previously, I think before 2019 or 2000, in that period, when we say the term Rogapati, many people will be having some doubts how this happens. But when during the pre-COVID era itself, we were having different waves of fevers coming to our state and affecting a lot of people. And we see when you look into a global perspective, we can see COVID-19 is a grave issue from 2020 onwards. But prior to that, there were waves of Ebola passing through Africa. Dengue virus infections spreading throughout Asia, Southeast Asia, Middle East, Africa, everywhere. Infections like leptospirosis, chikungunya, Japanese encephalitis happening. And we might have heard about a group of young children I think in many villages have been washed away or put into death due to the spreading encephalitis in many parts of remote districts of Chhattisgarh, Bihar, etc. And 2 years back, we got an attack of Nipah in Kerala. That was a very rare fever. And thus, every year we were facing different patterns of fever. And now, when we are in the grips of this COVID-19, many a time the sources like Facebook or some other social media channels have brought out the episode of Spanish flu, which came in 1920, etc. So, Jwara is actually Rogapati. Rogapati means the king of diseases or the supreme among the diseases. Why? Because a person who functions normally, who is in a physiological milieu, is suddenly brought into a pathological spectrum with rise in temperature and suddenly getting weakened, crippled, and succumbing to death. So, in an era where the medical care was very remote, when the number of Vaidyas were very scarce, and people were living very near to the forests, and other settlements were very close to remotest places on earth, there were chances of infections. And the ancient physicians who were put to battle these infections had rightly stated that this is Rogapati itself. Why? Because they have to develop strong theoretical background to explain what is happening to the patient. They have to devise medications, procedures, dietary modifications to those persons who are undergoing fever to maintain their Sharira Balam. And slowly they were taken back to life. And also they might have seen a lot of cases which were dying. And they have recorded those beautiful observations, even the chances of death, even the dates in which the people will die. That is being recorded in Nidana Sthanam in Ashtanga Hridaya Masvilasam Charagam when we refer Sannivada Jwara. So, when the people die, they thought that, or their theory was, or they have constructed a theory of Dhadubhaga. And when the people got rescued, they constructed a theory called Doshapagam happens. So, the duty of a Vaidya was constructed that it is rightly messaged in our Samhidas that the duty of Vaidya is to manage or regulate the Paga process. He has to oversee, he has to supervise the Paga process happening in the body of the patient, wherein the doshas, which are Sama, which is circulating all through the body along with Agni. And our duty is to empower the Agni, which has been expelled from the Koshta, to carry out the Dosha Paga and hence open the channels and return back to Koshta. So we are carrying out Dosha Paga efficiently without causing Dhatu Paga. And our intention, our therapeutic target is to defend Dosha Paga by any means. Defend Dhatu Paga by any means. Dhatu Paga surely will lead to death. And also, the one eye of physician is always kept towards the status of Ojas, the Bela of the patient. So, Acharya in the first chapter of Jara Chikitsa itself states that the Bela or the Rogi Bela is the cornerstone of Jara Chikitsa. And all the therapeutic interventions should be focused towards maintenance of Rogi Belam. And the Rogi Belam itself is sufficient to create Dosha Pagam and to defend Dhatu Pagam. So we see that when influenza waves happen, when COVID-19 wave is happening, even those countries with the highest reputation of doing technological medicine, providing all those sorts of equipments, are failing. Why? Because the patients who are coming for that facilities containing highly technological oriented interventions were already having weakened Rogi Belam or weakened the status of Ojas, so that they cannot themselves defend the strength of Jwaram. They cannot bear the strength of Jwaram. So how they can bear the strength of the treatment or the interventions? So we are day to day we are seeing how the failure of Rogi Balam is creating the advance of disease and succumbing of the patient to that particular Jwara. So the statement of Acharya that Jwara is Rogapati is being correctly defended during the COVID-19 pandemic. Some question and answers which we used to hear during these days: do Ayurveda provide management for any of these diseases? Any of these Jwara can be managed? If yes, whether how these diseases were referred in Ayurveda? This is a usual question. Can you treat cancer? So we say we can manage it. Then the next question is whether cancer is described in your Samhitas. Or can you provide treatment for an illness happening new in the society which is not described in the Samhitas? And our answer is yes, all these fevers can be managed with very well with Ayurveda. And no, these fevers are not directly referred in our classics. We do not have such an approach of classifying each and every clinical entity. But we have got broad classifications of a universal term called Jwara. We have created a model. We are having model-based approaches only. And we are having model-based approaches with the Doshi classification. And hence, by using those models, Ayurveda has a methodology to learn and provide solutions for new diseases. So prior to COVID-19, I remember the onset of Zika virus, and that results in microcephaly. At that time, I was reading in newspaper regarding the delegations or the inquiry of the global community regarding any solution regarding the prevention of microcephaly in Zika affected mothers. So naturally, if something happens beyond the capability of the technomedicine, such deliberations or such inquiries are naturally coming towards Ayurveda, and hence Ayurveda is capable to learn and to provide solutions for new disease from its therapeutic armamentarium. And our methodology is simple. We are focusing on Lakshana Samashti or the syndrome complex. The whole lot of description of Lakshana Skandha in Ayurveda. That means the entire Panchalakshana Nidhanam. And by using that element of the description of the disease, we are trying to build up an Abhyantara Vigruti Parampara. So we are going to construct an Abhyantara Vigruti Parampara for each person affected with a particular disease. So that Abhyantara Vigruti Parampara is going to solve the question at hand. So we are having a new disease called COVID-19, and by assessing the Lakshana Samashti of each and every patient, we will develop a very personalized Abhyantara Vigruti Parampara for every patient. And by using that Abhyantara Vigruti Parampara, the term Parampara means a cascade. It's a continuous journey. That means when the physical body is exposed to Nidana, and when the Guna Vidyana happens, the Dosha Vidyana happens, the disease will happen. So when the disease happens, how it is proceeding, what all Srodasas are affected, what all Dhadus are affected, and as the Dhadu, Agni, Srodasas are affected, how the disease is going to harm the body. And what happens after the disease, whether any new Upadrava Roga will start and kill the person. What are the udarkas of this particular phenomenon? So in that way, we are constructing an Abhyantara Vigruti Parampara. And by using that Abhyantara Vigruti Parampara and models which are mentioned in our textbooks, we can suitably pick up a particular protocol from our textbook and administer to a specific patient. That means all our approaches, all our efforts are person-centric, or we are centering around the Rogi for delivering a particular type of protocol to that particular person for that particular program. So regarding Jwara, the signature clinical feature, I talked about the Lakshana Samashti. So we are focusing on the signature clinical feature, Sandabo Deha Manasa. The change in the normal internal milieu of body and mind, which is recognized as rise in temperature. So simply stated, all Jwara is simply a fluctuation in the temperature of the body or temperature regulating mechanism of the body that may have been resulted from a change in the internal environment of the body and the mind. So not only the body but also the mind is a factor when Jwara is taken into consideration. So this Sandabam happens in the body. So what is the signature pathological feature or the cornerstone pathological feature happening? We are seeing Agni for the first time in the Shakha. Already the branches of Agni are present in Shakha in the form of Dhatu. It's right. But we are now seeing a complex called Agni and Samadosha, which is being circulated in the Shakha, raising the temperature in the Shakha, whereas the Koshta is devoid of Agni. So we find that the Koshtam, there is Agni is totally expelled from the Koshtam, and after this expulsion, this Agni is seen circulating in the Dhadus along with the Samadoshas. So this happens to be the signature pathological feature of Jwara. So Jwara, why many a time the question happens that why Jwara is being mentioned first in the textbooks. So the reason is that this type of expulsion of Agni is seen only in Jwara. Agni, in all other diseases, Agni is placed inside the Koshtam and variation of Agni happens there itself. But here in the case of Jwaram, the variation happens when Agni is thrown out of the Koshtam. And hence, the Jwara happens to be a disease of contrast. The patient says, I'm feeling very cold. And the physician says the patient is felt to be very hot. So at the same time, the symptom which is felt by the patient and sign which is felt by the physician, both are in deep contrast. This contrast is being properly explained in Ayurveda by the presence of Agni in the Shakha and the absence of Agni in the Koshtam. I think you got the situation, the entire soul of the situation. So the expulsion of Agni from Koshta, circulation in Dhadu along with the Samadosha, and consequent rise of Tabam at Shaka and Shaityam at Koshtam happens to be the characteristic features of this illness. And we study disease models rather than diseases, as all of us know. Hence, we can accommodate any new pathology with ease. It's very easy to construct a Samprapti for a particular disease for a particular person because we are having universal or umbrella type models which are being taught to us. And personalization happens to be our greatest advantage. Any model you take, Jwara or Raktabita or Kasa, Swasa, Rajayakshma, Arshas, Grahani, Adisaram, any model, to that particular model, you can add the personalized features, the features of a particular rogi in the form of Dashavida Pariksha. And in that way, you can derive a specific protocol from that particular model. And this is the beauty of Ayurveda. And we do in this sequence, we identify the right model by using Vyadhi Pratyatma Niyada Lakshana, as I have told that for Jwaram, Sandabo Deha Manasa is the Vyadhi Pratyatma Niyada Lakshana, and Abhyantara Vigruti Parambara is constructed. We explore that particular model by placing the specific details of the patient and we arrive at a diagnosis. And for us, the diagnosis doesn't mean a term. So that's why Acharya says, Vigara Nama Akushalo Najiti Kadajana. For us, the term, by telling a term, the diagnosis never ends. We describe the patient in the form of diagnosis. Our diagnosis is very descriptive. So, in that way, by using a descriptive diagnosis, by even incorporating the avastha of patient into that particular diagnosis, even if we have got no term to say, we can say this particular dosha residing in this particular dhatu have moved through this particular srotas, now in this particular roga margam, is creating this type of symptoms, is in this particular avastha. Samavastha or Miramavastha or Jirnavastha or Pakvavastha likewise. So this is the diagnosis in Ayurveda. And as per that particular description, we select the specific procedure, internal medication and a regimen for the particular patient, apply it to the patient, seeing the result. For example, we see temperature rise and the way it happens. We identified the model called Jvaram. The Nidana may be exposure to rains, intake of cold ice cream and excess spicy food for long duration, exposure to AC. So there is a Kapha Vitta Vritti, which is now focusing at Urdhvangam, that might have been resulting in a sinusitis or tonsillitis. Now we are selecting a specific protocol. We are advising the patient to use Ushna Jvaram. Lina Pitta Anila Sweda Shagarat Mutra Anuromanam. So that single line describes how to place the therapeutic targets. We have to create anilomanam of Lina Pitta, Sweda, Shagarat Mutra, etc. And also if there is Pittanubandhitvam, we fear if Pitta is going to come up and resulting in some catastrophes, we will change the Ushna Jalam into Shadanga. So there are innumerable choices available to us. But the importance is to plot where to plant the attack. Where is the correct cornerstone of pathology resides? Where you have to operate. In that way, from innumerable number of medications, procedures, dietary patterns, you have to derive a particular protocol for a particular patient. That is a challenge in front of us. So now the question arises, if you can treat every Jvara like this, how you will understand the Jvara will be turning fatal? And now we see several patterns. When you go through the Samhita, you can see that when Egadoshaja or Samsargaja Jvara turns Sanipadika, there is every chance that it will turn fatal. Okay. And when Sanipadika Jvara attains the status of Hridaujas, in Ashtanga Hridayam, there is a term called Hridaujas, which is mentioned as a synonym of Sanipadika Jvara. Hridaujas means in a Jvara where the ojas is destabilized. Hridam means one which is taken away. So when ojas is being taken away, the patient will die. When the doshas are away from Shodhana Marga, doshe vibadhe, when Agni is very weak, nashte Agno, to create Pajana, or when Jvara ensues with the full Rupa, you can see that doshe vibadhe nashte Agno sarva sambhurna lakshanaha, Jvaro asadhya. That results in asadhyatvam of Jvara. And also, when Dhatu Bhaga happens and Dosha Bhaga remains a distant possibility, when there is inherent weakness of Dhadus. Many patients die because of inherent weakness of Dhadus, not because of Jvara. When the patient is having reduced Dhadusara, reduced ojas, destabilized Bela, compromised Vyadhikshamatvam, all these results in turning of fatality. So when we go through many textbooks, especially those of Kerala special textbooks, we can see that the one segment of the chapter will be denoted to Egadoshaja, Samsargaja, Sanipadika Jvara, etc. The other segment will be devoted to Sanni Chikilsa. Sanni Chikilsa means, especially in the case of Chikilsa, Sarvaroga Chikilsa Ratnam, etc. in such textbooks as used in Kerala, we have got a special chapter called Sanni Chikilsa, where the medicines which are some sort of step up. We have to step up our clinical aggressiveness. Previously, for Vada Kapha Jvara, you will be using Vyakhyadi Kashaya. For Paitika Jvara, you will be giving Sudarsana Gulika. But when the Jvara turns fatal, the clinical aggressiveness need to be stepped up. So what will happen? So your treatment pattern is going to change. You are introducing a new Kashayam called Daru Nagaradi to counter the excess Vada Kapha Pradhana Sannipada Avastha. And also, if there is intolerable Pitta, you have to introduce Suvarna Muktadi Gulika. So in that way, different varieties of new medicines, new procedures, you are keeping Talam, in the form of Rasnadi Churnam or Kachuradi Guliga when the disease turns fatal. So every other mechanism is brought into action to prevent the fatality. So this type of interventions we have now demonstrated in advanced COVID cases throughout India. I got a chance to interact with the different physicians, especially in North India, who have practiced with the Jayamangala Rasa or Sukshma Trifala, Mahalakshmi Vilasa Rasa, Pradyabalangeshwaram, Ananda Bhairava Rasa, Godandi Bhasmam, Vasanta Kusumagaram, whole lot new preparations. Especially those preparations were not frequently used in our place in Kerala, is being employed in northern parts of India to rescue people with the compensated oxygen saturation. I have seen many cases. So I have heard about, or I have been informed about such cases where the oxygen saturation was falling steadily down, and all these medicines, wonderful Ayurvedic medicines, when they are administered, the patient was wonderfully relieved, or they came back to life. Different examples are available for that. So COVID-19 and the ICU management by using Ayurvedic therapeutics have instilled a great confidence in physicians throughout India, Ayurvedic physicians throughout India, that even in ICUs, Ayurvedic medicines have got a very big role to bring the patient back to life. We have seen the employment of different types of mechanisms, that patients might have been placed in ventilators, or they might have been given high dose of steroids, or they might have been given other medicines, HCQs. Still, there was no chance of recovery. And when Ayurvedic medicines are properly instituted, especially those mentioned in such advanced cases, the patients were revived back to life. So what I am going to say that the utility of Ayurveda should not be restricted to those cases which are very moderate or mild. No, every type of jvara is amenable to Ayurvedic medicines, and we have got a treasure trove of medicines, not simply 1 or 2 pages. It's a huge treasure of medicines are available with us, and we have to study daily how these medicines can be differentially employed for management of different diseases. So my slide contains specific contents like pneumonia, dengue, chikungunya, and influenza. And I am specifically focused, no excess focus on facts available easy for reference. I'll be stating certain facts which will be throwing light on the basic nature of these type of fevers. And then I am trying to develop a focus more on the elaboration of Ayurvedic approach. So how we can perceive these clinical entities. I will say Jara is a huge clinical model. And these pneumonia, dengue, chikungunya, influenza, all those are single clinical entities. So standing with that model, how we can go through the details of these clinical entities and how you can perceive an Ayurvedic approach, how you can see these clinical entities by using an Ayurvedic eye. This is what I am going to approach. This is what I am going to try to do in this presentation. So the first one I want to talk about is the dengue fever. All of you know that it is known as breakbone fever or bandy fever. There is high fever, severe pain of bones and joints, lymphadenopathy, some characteristic rash may be appearing. Benjamin Rush was the first physician who described it in 1789, mostly seen in tropical and subtropical areas of India, Africa, Southeast Asia, China, etc. Characteristic feature is common during and shortly after the rainy season. So after the Varsha Ritu, when Sharad Ritu appears, there is a chance of this particular fever to happen. This is what we derive from this data. It is endemic in India since last 2 decades. And the status of India, we've seen large outbreaks, very common in India after 2000. Typical outbreaks in Kerala, recurrently after 2003. An outbreak currently happening in Uttar Pradesh. Now reports are coming that outbreaks of dengue. A huge number of people belonging to some villages are getting admitted to the local medical colleges. And up till May 31st, 2021, we have about 6837 cases of dengue in India. So, dengue fever is currently going on in many parts of northern India. The etiology is four distinct serotypes of dengue virus. So, DEN denotes dengue, 1 denotes the serotype 1. So, dengue 1 to dengue 4. It is a single-stranded RNA virus belong to a group called the arbovirus group. That means arthropod-borne virus. This means that, as all of us know, these virus cannot enter directly to our body. Needs a blood-sucking arthropod to transmit it from one vertebrate host to another. There are two different vectors, Aedes albopictus and Aedes aegypti, which is causing this disease. These two mosquitoes, they are freshwater breeders, domestic surroundings, bite all times during the daytime, but they have got a tendency to bite ankles and feet at dawn and dusk. They do not fly long distances. But during the last outbreak, I think 2 years back, there was a study coming from Cochin where previously the dengue, this Aedes mosquito was seen only in the ground floor or first floor or second floor of the flats. But later, as the studies show, they are capable of flying up to fourth or fifth floor. They are enhancing their capability to fly up. So the man is considered as the best reservoir of this infection. And this disease is classified into three, that is dengue fever, dengue shock syndrome, and dengue hemorrhagic fever. This happens in this particular way, that is bite of infected mosquito happens. Virus comes into the regional lymph nodes, replicates there. It is getting disseminated via lymphatics and blood. Viremia means when there is presence of virus in the blood. It starts within 3 to 7 days. It happens to subside in a self-limited way, and virus persists in infected mononuclear cells. This happens like this. That means the first attack of dengue may be going in a very self-limiting way. You will be getting a fever, getting naturally subsided by 3 to 7 days, but there will be persisting virus inside the mononuclear cells. When subsequent attack happens, what will happen? After the first attack of dengue, there will be every chance of a long-term specific immunity, but that may fade after many months. An infection by a different serotype may happen. When a different serotype, see the last sentence, dengue 2, den 2 followed by den 1 happens to be more serious. Somebody getting a dengue virus infection by the subtype 1, followed by an infection by subtype 2. So that results in more serious types of attacks. So that means if subsequent attack happens, that subsequent attack will be more dangerous.
Excuse me, sir, are you presenting something that's not showing? Okay.
So okay, can you see this?
Yeah, subsequent attacks. First attack of dengue. That's the heading now.
Now what about this?
Subsequent attacks.
Can you see this?
Yeah, that heading I can see.
Yeah. Now is it moving?
Yeah. How DHS and DSS turns favor.
Yeah. Please let me know if something happens in between.
Yeah.
So such subsequent attacks will be creating more serious illness. That means a normal dengue infection or dengue fever may turn into DSS, dengue shock syndrome, or DHF, dengue hemorrhagic fever, due to subsequent attacks, especially by a different serotype. So the hallmark of this subsequent attack is the increased fragility and permeability of capillaries. We have to note this point. What is the value of studying this clinical entities? This is one question. Shall we only focus into Jwara, Raktapitta, Kasa, Swasa, etc.? Natural question to a Roga Nidanam specialist. My answer is, by studying the clinical entities, we can be more focused. See, the focus of DHF and DSS is towards the capillaries. So we will be more focusing towards the Rakta Dhatu or the Sira, etc. So our focus will be more on the catastrophes that is going to happen in the Rakta Dhatu. or that gives us a hint that if there is some dosha vitiation, especially to pitta dosha, dengue fever can become fatal. So we are getting more efficient clues that can focus our medicines to specific dhatus by studying these clinical entities. That means we are sharpening our model-based knowledge by using this clinical entity knowledge. That is my perception regarding that. So the fragility and permeability of capillaries that focuses our attention towards the Rakta Dhatu. Abnormalities in hemostasis may happen. And more than that, during this process, an antibody virus complex may form. And when this complex forms, the virus gets somehow an entry into mononuclear cells and lymphocytes and persists there. And when this reaction happens, a lot of cytokines will be pumped into blood, like TNF alpha. And what happens is, these cytokines will lead to endothelial swelling of small blood vessels and perivascular edema will occur. See, perivascular edema. Pitta rakta kaphan vayu dushto dushtan behisira nitva ruddhagadi tai kuryuhu twang mamsa samsridam utsedham sampadam shobham. So the clinical entity of shobham, our model of shobham is coming into forefront. That if you can recognize the presence of another model along with the jwaram, you will be benefited by the fact that you have got another set of choices of drugs and procedures which can be taken up from the chapter of shobham. So this endothelial swelling of small blood vessels, perivascular edema, all point to the presence of a sama shobham. In complicated cases, there will be arrest of megakaryocyte multiplication of bone marrow. Yes, the production of Rakta Dhatu is being abnormally vitiated. There is a metabolic defect in the formation of Rakta Dhatu. That is what is happening in the Samprapti or model called Rakta Pittam, wherein the formation of Rakta Dhatu is affected. A new entity, a deviant variety of Rakta called Rakta Pitta is formed. Thrombocytopenia happens. And hemorrhage may ensue because of thrombocytopenia, platelet dysfunction, coagulopathy, generalized abnormality of vascular endothelium leading to extensive fluid leakage in the body. So the vascular compartment, which is very much sealed, which is very much flexible, that flexibility is being taken up by the pathological process, and that lead to the excessive spilling of the fluid component inside the vascular compartment, that leading to excessive fluid leakage. So at one area hemorrhage may happen, the other area excess fluid leakage may happen, and hence the patient may succumb. And now we have got different varieties. That is, the first time we'll be having undifferentiated fever, which may be mainly asymptomatic. Self-limiting type may present with fever, malaise, some upper respiratory symptoms and rash, and then they end as itself. No problem will happen. And then there is another set of symptoms called a classic dengue fever, where the incubation period is 3 to 8 days. There will be fever and headache, muscle pain, bone pain, joint pain, etc. That starts as mild, slowly builds up in proportion, and becomes severe in 1 to 2 days. There will be retroorbital pain. There will be lumbosacral ache. We can just remember the slogan of Kapavada Jwaram. Tabahani Aruji Parva Shiroruk, Pinasa Shosana Kasa Vibandha. Sida Jadya Timira Brahmatandra, Skleshma Vada Janita Jwaralingam. Just think of that set of symptoms which has been mentioned as the classical clinical features of a Kapavada Jwara is being characterized in this classic dengue fever. There is occurrence of a maculopapular rash, generalized myalgia, some anorexia, nausea, vomiting may occur. Posterior cervical, inguinal, epitrochlear lymphadenopathy may happen. And all these symptoms are mentioned in this figure. Eye pain, headache, rash, muscle pain, bone pain, joint pain, nausea, vomiting. All these happens to be the features of classical dengue fever. And they say that the initial fever subsides by the third day, returns back after 2 days, then lasts for 3 days. The second episode will be milder than the first one. So this pattern is just like that of a saddle which is placed on a horse. Hence it is known as saddleback fever. The hemorrhagic phenomenon, we will see that there are petechial hemorrhages, ecchymosis will happen at injection sites, epistasis and menorrhagia may happen. So, when you are treating a patient with a dengue fever, even if the patient is not communicating us, it's our duty to question the patient regarding any hemorrhagic phenomenon in her body, especially if she is menstruating. We have to ask about the volume of the menstrual blood which is being passed out and whether that is having any significance with this particular disease process. This may happen during illness. And the transition phase happens slowly. How the patient is being tracked. From febrile phase to critical phase, gradual transmission occurs between days 4 and 7 of illness. Indolent illness gradually turns fatal. The clinician's eye should be on this transition phase. So whenever you manage dengue fever, if you are properly read about this particular literature, our eye is always on the patient whether this particular patient is entering into a transition phase where the classical dengue fever now is getting into a complicating phase. The signs of deterioration are persistent vomiting, severe abdominal pain, tender hepatomegaly, increasing hematocrit values, and development of severe thrombocytopenia. Then further changes may happen suddenly. There will be the onset of shock, rapid deterioration from second to fifth day. Hemorrhagic manifestations will become severe when platelet count falls below 20,000 and that will warrant an immediate transfusion. Liver failure, myocarditis and encephalopathy may appear. And regarding this, then we say that dengue hemorrhagic fever has started. The grade 1 dengue hemorrhagic fever is fever with easy bruising, positive tunicate test can be seen. Grade 2 when there is spontaneous bleeding, skin or other hemorrhages we can see. Grade 3 there will be rapid weak pulse, thready pulse. That means the volume is very less, weak pulse but it is very rapid. Hypotension is there, narrowing of pulse pressure is there, cold clammy skin and the patient will show restlessness. Restlessness points to arrhythmia. Arrhythmia is one of the important signs of Dhatu Bhagam. That means when Dhatu Bhagam happens, the patient will be having severe restlessness. Restlessness means they are not getting any comfort in any position. So sudden changing in patient's mood, sudden changing in demands of the patient, all those signify restlessness. And then the grade 4, there will be profound shock with the undetectable pulse or blood pressure will happen and the patient may die. So here the dengue hemorrhagic fever has slowly rapidly transitioned into dengue shock syndrome. The Lakshanas of Dhatu Bhaga mentioned in Bhava Prakasha, that is Nidra Nasho, Hrudistambho, Vishtambho, Gaurava, Ariji, Aradir Balahanischa Dhadunam Bhaga Lakshana. Aradi is one important component. So we have to observe the patient always whether anything happens. That should point towards the onset of dengue shock syndrome. So meticulous observation of patient, continuous physical examination of the patient and recording. So every hour BP monitoring, looking for any hemorrhagic spots on the patient's body, questioning the patient, also looking into the patient's shift in attitude and pattern, any evolution of the symptoms like restlessness. All these will point to the rapid deterioration and succumbing of the patient. So we have to act fast. And DSS happens to be the most serious complication of dengue fever. As I have told previously, restlessness, abdominal pain, shock, rapid diaphoresis, clammy skin, circumoral cyanosis, change in mental status. See, circumoral cyanosis, a sign of sudden onset, reduced oxygen saturation. Rapid diaphoresis, happening, narrowing of pulse pressure, hypotension, all those point to the onset of shock in a dengue patient. And usually investigations doing not at the time of this dengue shock, instead prior when the patient is getting admitted, blood routine that may show leukopenia and neutropenia, thrombocytopenia, leukopenia or neutropenia very common in any viral infections. Chest X-ray may show some pleural effusion because of rapid leakage happening in the endothelium. Urea creatinine may elevate in complications. There will be attending renal damage. So Shopa Samprapti ensuing, renal damage is happening, Raktapittam is happening. All these should be kept in mind when you do investigation. And the classical diagnosis is by doing dengue NS1 antigen by using ELISA for specifying this is dengue fever. The prior investigations like the blood routine will support or will inform you about the deterioration happening in the patient. And dengue IgM antibodies is also available for correct specific diagnosis. And regarding Ayurvedic approach, I may say the dengue fever start as a Vada Kapha Jwara or a Vada Kapha Pradhana Sannipada Jwara. It may proceed as such and end. It can happen like that in the undifferentiated fever pattern or in the initial phase of dengue fever. May have a flare-up of Pitta or the patient may be a Pitta Pravati patient, and there is every chance of this Jwara turning into Tridosha Pradhana Sannipada. Leads to specific dushti of Raktavahasrodas. The Raktavahasrodo dushti or Pitta Pragoba might be triggered during the initial attack. Also, that should be borne in mind. A patient who is having a past history of dengue fever, even after fever is continuing those food items or those pattern of life that is triggering the Pitta dosha. So that harbors a Pitta Sanjaya in his body, and when again dengue infection happens, that Pitta Sanjaya will get into Pragoba. That will lead the Samprapti. So the presence of a Pitta Pragoba or Pitta Sanjaya has to be taken into consideration. The patient might have used Pitta Dushti Nidana in between attacks. So the circulation of Samadosha and Agni, which specifically resides in Rakta Dhatu in this case. So when it resides in Rakta Dhatu, what happens? There will be a leakage, endothelial leakage. There will be one branch is proceeding towards Shobham. Dosha Bhaga is not happening. Rapid Dhatu Bhagam is happening. There is destruction of Rakta. There is a destruction of the metabolic pathway which creates the Rakta. And a new entity called Raktabittam is being formed. Raktabittam means there is Ushna Drava Guna Varthita Rakta. You see. So Charaga correctly states that Tasyoshmana Dravor Dhadu Dhador Dhadu Prasichade Siddhyadastena Samruddhi Uyastat Adigachati. When Raktapitta happens, here the concept of Upadrava is also coming in. Upadravastu Kalu Yogasrayo Roga Eva. It is also told that Upadrava is due to the presence of a predominant dosha at the time of onset of a particular disease, due to the effect of the predominant dosha. It is due to the presence of that particular dosha, which is highly vitiated, that it runs the disease and creates a new disease. So, in that particular case, because of the presence of a predominant pitta in Sanipadika dosha dushti, gradually an upadravam called Rakta Pitta ensues. And because of Rakta Pittam, the patient succumbs. And there will be attending Shopa Samprapti. So here, 3 Sampraptis have to be taken into consideration. Jwara, the Samprapti going on, Rakta Pittam can ensue, Shopam can ensue, and hence Dhatu Bhagam will continue, Dosha Bhagam will not happen, Rakta Dhatu is specifically destroyed, and hence the patient dies. The management principle is one important slogam from Ashtanga Hridayam comes to our mind when we manage then hemorrhagic fever or shock syndrome. Here, Ushma Pitta Dride Nasti, Jwaro Nasti Ushmana Vina, Tasmad Pitta Viruddhani, Tejet Pitta Adige Adigam. So from initial attack onwards, Pitta Shamanam yet Dosha Pajanam shall be the approach. Is there any contradiction? Pitta Shamanam yet Dosha Pajanam. So create Dosha Pajanam, we require Ushna. Yeah, but the dosha here is Pitta. How will you manage this? So for that, Pitta Pajana Aushadhi, which is having Pitta Rasam, yet having Shida Vidyam, yet having a Pajana Guna in that, is sufficient to create dosha pajanam, but it will not create provocation of Pitta dosha. So the Shadangam Panam, Kanajandana Sundhyambu, Parpadosira Sadhidam, Sidam Pepyo Hidam Toyam, Pajanam Tritjvarapaham, Pepyo. One important term points towards Ushnamevam Gunatvebi, Yunjat Naiganda Pittalai, Udrikta Pitte Devadu, Daha Moha Adisara Karini. So, in that way, those jwara in which there is an increase of pitta, in that cases, you have to go for pajana by using Shadangam Panam. It is correctly indicated in Jwara Chikitsa. Also, in the initial phases, Amrudotram Kashayam, Vyakhyadi Kashayam will be wonderfully working. Then there is Gopi Chandranadi Guliga, Sudarshanam Guliga. All those focusing on pajanam, yet they are having a control over Pitta dosham. If the respiratory problems are superseding, Lakshmi Vilasa Rasam will be good. And Sudarshana Churnam, if there is profound Pittadikam. Sudarshana Churnam is Tikta Rasam. It is having Rejana function. It is advised to give Sudarshana Churnam in cold water. And Sudarshana Churnam is if given in Shadanga Panam, is the best choice for reducing the predominant pitta. If you suspect DHF, DSS, etc., introduce Vasha Guluchi Adikashayam, Vasha Guluji, Trifala, Katvi, Punimba Nimbaja, Kathak, Shaudari Yuto Gandhi, Pandu, Pittasra Kamala. So, Pittasra, Rekta Pitta, which can lead to hepatic disorders like hepatomegaly or Kamala, likewise. And also it can lead to red cell destruction resulting in anemia. All that can be managed by giving Vasha Guluchadi Kashayam. Also, Drakshadi Kashayam will be useful, which is mentioned in Vada Pitta Jwaram, which I have not mentioned here. In order to put an end on the Rakta Dhadu Dushti, Manjishtadi Kashayam mentioned for Vada Rakta, that is Manjishta, Tripala, Tikta, Vaja, Daru, Nisha, Muda. Vaja, except Vaja and Daru, all the other are Tikta Pajana Aushadis. They are Sida Virya, but they are Pajana in nature. Vaja and Daru are Ushna Virya, but they are being scaffolded in another set of drugs, which is not harmful. So, Manjishtadi Kashayam, which is Vada Rakta Samanam, also which is having a good effect on the Rakta Vahasrodas, as well as Punarnavadi Kashayam, Navadi, which is having an impact on Shobham, Pandu. All those can be employed here to prevent the ill effects of Shobha Samprapti happening here. Artha Vilyam Kashayam is also another good choice over here. Chandraprabha Guliga, which contains Shilajudu, which is Shida in nature, yet Pajanam, yet Chedanam in nature can be given here. Also, Pravala Bhasvam Rasasinduram combination is also giving good results. And after initial attack, when Jadra, and also I will say, if DHF is happening, you can have Kachuradi Churnam for Talam, and also you can employ Suvarna Muktadi Guliga along with the honey. That 2 points I have missed in slides. That is use of Suvarna Muktadi Guliga, use of Drakshadi Kashayam, use of this Kachuradi Talam. All these will be having an effect on the Samprapti, the fast progress in Samprapti. So when Vada and Pitta are involved in some Sampraptis, that Samprapti will start fatal very fastly. So to reduce the pace of Samprapti, you have to give the drugs like this, Suvarna Muktadi. And also Mahalakshmi Vilasarasam, which contains gold, is also effective in reducing the pacing of the Samprapti. And then after initial attack, when Jadrakni and Dhatukni still in a Vishama Avastha, it is good to go for Indugandham Kashayam. Thereafter, once attaining stability, go for Chevanaprasam and later Pittaka in small doses to reduce the ill effect of Pitta, so that if a next attack happens, that should not lead to hemorrhagic fever or shock syndrome. This protocol will be good for such patients. So this much about the approach to dengue fever. I may say this is not a complete approach, because a lot more equipments are there in our Samhitas. So what I am trying to tell is that we can derive certain protocols for dengue fever by placing the Jura model as well as the clinical entities like dengue hemorrhagic fever, dengue shock syndrome, etc. And also we brought the components of Jura Samprapti, Raktapitta Samprapti, Shobha Samprapti for managing this dengue hemorrhagic fever and dengue shock syndrome. And then chikungunya. Chikungunya also caused by a virus which belongs to the same family of arthropod virus group. Sudden onset of severe joint pain which cripples the victim. Symmetrical polyarthropathy is there. And the interesting fact is that in Kerala, when in 2008-2009 time, when there was a rapid advancement of chikungunya fever, it was the first time that in Kerala government has agreed to use Ayurveda widely for prevention and treatment. So not for prevention, for treatment of this particular illness. And we have seen that those patients who have taken Ayurveda has very little residual polyarthropathy. Chikungunya, one important feature is that even after the subsidence of fever, many patients will be getting residual polyarthropathy not only for months, it may last for years. And it can be explained similar to our concepts of Dushi vision, wherein we were getting after, I think from even up to 2018, we have seen cases coming to our OPD, especially during rainy season, with the increased swelling, difficulty to walking, etc. Those were patients who were affected with the chikungunya and escaped from that 10 years back. So there was a long-standing residual polyarthropathy, and especially in patients who used Ayurveda, this residual polyarthropathy was very minimal. So actually, chikungunya episode, I may say that at that time of attack, we were given a lot of support from the government to use our medicines to counter the ill effects of chikungunya. So that reduced a lot of fatality and morbidity to the patients. And here, sometimes rarely hemorrhages, CNS symptoms may happen, and sometimes the patient may die. Widely seen in Asia, Africa, and Middle East. And 1964, there was a big outbreak, big massive epidemic happened in Tamil Nadu that has been well studied. Even serological studies were carried out at that time in Madras. And in 2004 to 10, different outbreaks of chikungunya happened in Kerala. Vectors are the same. Incubation period is 2 to 10 days. Abrupt fever with the chills, rigors, headache, joint pain may happen. Mild conjunctivitis and pharyngitis. One J is missing there. Severe inflammation of joints may happen. Standing, walking becomes excessively painful. Symmetric polyarthropathy, sparing shoulders and hip. Small joint of hand and feet affected. And I still remember in OPDs, the patients who are having preoccupied wear and tear of the joints, who are long-standing daily wage workers, who are having some joint problems, degenerative joint disease. Also, those people who are very much fatty, non-exercising, above middle age with a lot of degeneration in their joints. For them, the chikungunya attacks were very severe. Their arthropathy were very severe. Pain is excruciating, hence crippling. The patient may be crippled to bed because of the severe pain. Fever and joint pains may start subsiding by the 6th day. Residual also arthropathy may last for years. There will be severe morning stiffness. The progression is generally benign, but slow recovery only happens. So there will be a lot of loss of working days. The patient may be crippled to the home he cannot go out, take a vehicle, or get into the bus, do the routine activity. All the activity will be affected. Polyarthropathy may persist, may mimic many times with rheumatoid arthritis. So it was during these past 10 years when people came with the complaints with the multiple joint pain, especially small joint pain, morning stiffness, etc. The usual question in Kerala's OPDs were whether you have any past chikungunya-like fevers, any viral fever with the joint pain might have happened in your life previously. That was a very usual question. It may turn fatal for infants and very elderly people. At that time, when chikungunya was very at its peak in Kerala, every day in newspapers there was mentioning about people who died due to this disease. The only technique to identify this was IgM antibodies against the chick virus for serological diagnosis. The rest was clinical diagnosis. When you get a patient with swelling of joints, pain of joints, difficulty to walk, crippling, morning stiffness, small joint affliction, polyarthropathy, all these combined together to give a diagnosis of chikungunya. And the Ayurvedic approach, usually this can be correlated to Vada Pradhana or Vada Kapha Pradhana Jwaram. Why I say Vada Pradhana Jwaram? Why? Because of the different type of pain features. When you go to the text and see the sloga of Vadiga Jwara, Agama Abagama Kshoha, Mrududa Vedanoshmana, Vaishamyam Tatra Tatrange, Tastasyur Vedanaschala, Padayo Suktadastamba, Indigo Dveshtanam Jwara, Vislesha Iva Santinam, Sada Uru Padigraha, Prishtam Chodam Ivapnodi, Nishpidya Daivodara, Chidyan Daivachastini, Parshagani Visheshada, Pradayasya Grahastoda, Prajaneneva Vakshasa, Skandayor Madanam, Bahor Vedaha, Pedanam Amsayo. In this way, a lot of pain features are being mentioned specific for each joints when you describe the Vadiga Jwara. So, many features may be floating towards Vadiga Jwara or Vada Pradhana Kapha Anubandha Jwara. Such features may also be seen in many patients. And it may turn into a Sanivadiga Jwara at any time. Because when the patient is getting into severe body pain, loss of sleep, occasional sweating, reddishness, lacrimating eyes, all point to a turning into a Sanivadiga Jwara, wherein the patient slowly shift into from a Vada Pradhana Avastha to Vada Pitta Kapha Pradhana Avastha. Be careful if host factors are not favorable. Many a time, these infective fevers happen. We will read a lot about the guest factors. That means what about this virus? What is their incubation period? How is getting spreading? And after spreading, what should be the test to identify? And all these factors are good. But for us, we have to focus on, turn our torch also into the host factors. If host factors are not favorable, why I am saying this? In Kerala, there is a approach of managing the lifestyle diseases by using allopathic medications. So many a time we have seen that the allopathic medications for lifestyle diseases are given free of cost from the primary health centers. And hence the patients are more medication dependent to manage the lifestyle disorders instead of changing their lifestyle. So those persons who are having a previous history, a long-standing history of diabetes or hypertension, previous history of myocardial infarction, COPD, dyslipidemia, hypothyroidism. So all those categories of patients are having unfavorable factors when such Jwara happens in the body. So such patients will be crippled more fastly if they are obese, if they have got degenerated joints. All these tend to bring them fast into the bed when this chikungunya happens. And in Vada Pradhana or Vada Pradhana Kaphanubandha Avastha, the target is to counter the Vishama Avastha, accelerate Dosha Vajanam, open up the rasa and Svedavaha Srodas. Ushna Pajana Devya, yet maintaining the Ojo Guna is advisable. So, Indugandham Kashayam. വാതാമയ ക്ഷയ മഹോദര ഉൽമശൂല നിമ്നോന്നത ജ്വരഹരം ബലവർദ്ധനം ച. So the bela is to be maintained at any cost in any type of jwara as per Ayurveda. So Belavardhana Nimnonada Jwarahara Kashaya is Indugandha Kashayam. So Indugandha Kashayam was used very commonly when we were having a chikungunya episode. Also the Dasamula Gadatrayadi Kashaya, which is focusing its therapeutic target on different types of joint pain along with the Urdhvanga Doshavastha. That is also the Dasamula Gadatraya Sama Dasamula Gadatraya Vasha, along with Vasha, along with the honey you have to give this Kashaya. Swasana Anila Kasa Parsha Prishta Trigamurtha Rujasu Sambradishta. So in cases where there is Samadosha residing in different joints creating different pain features, Dasamula Gadatrayadi Kashaya was having good therapeutic use. Dasamula Panajalam as Marma Samrakshanam can be given. Vetumaran Guliga, Vada Gajangushirasam, both for reducing pain features is good. And for residual polyarthralgia, we used to give Rasna Saptagam Kashayam, Vetumaran Guliga, Shatkarnam Churnam, Manjishtadi Kashayam. Rasna Saptagam is a wonderful combination in that it is having Rasna, which is Vedana Haratvam, Amrda, which is having a potential effect on Rakta Pitta Samanam, Devadari, which is Pajanam, Trigandagam, Erandam, Punarnavam. All those are Anilomanam, Shobharam. And in that we are adding Shundi Churnamaspakshevam, which is excellent Pajanam, which is Kadu in Jasam, Makiram in Vipagam, yet Shobharam. And so that's a very wonderful combination that can give good results in residual polyarthralgia. And also there is Shattarnam Churnam, Manjishtadi Kashayam, Dasamura Gadatrayadi Kashayam, Indugandha Kashayam, Punarnavadi Kashayam, all those were wonderfully used in residual polyarthralgia. Also, Gugula Galpanam, Saptasarang Kashayam, Sahajaradi Sadaila Kashayam in later stages only. On initial phases, we were not administering any Thaila internally, but on later stages, if we are very much confident that Amapajanam has happened, in that stages, Sadaila Sahajaradi was used, and Agastya Rasayanam as a drug which is having good effect on this type of Vata Kapha Jwaravastha or such type of Jwara where there is persistent Rasadushti was happening. So to make the Dhadus more Belya, in later stages when Amapajanam has happened, Agastya Rasayanam was a good choice. In IPD, if you get a patient with residual polyarthralgia due to this chikungunya, Vasti protocol with Dhanyamla Vaidaranam, Madhu Thairika, all those were sequentially administered in a patient. Then Dhanyamla Segam for initial period, followed by Avikiri with the Koilagulathadi Churnam, which is heated from the steam of Dhanyamlam was employed. Thereafter, Patra Podara Svedam with in a Ruksha way, then followed by Snigdha way of Patra Podara Svedam. Appropriate Lebanam at joints were provided. For example, if there is Vadagapha Avastha, we will be giving Nagaradi Leva Churnam or Vrihadumadi Leva Churnam. When there is Pittani Bandhutam, Rakta Dushti, etc., Jadamayadi was given or Guluji Patradi Levanam was given. So in that way, in IPD, we used to manage the patients. And coming to the another disease called influenza, or the other term, it is flu. Very common viral disease presenting as an acute febrile illness caused by influenza ABC virus. There are three human subtypes, H1N1. We are very familiar with the term H1N1, H1N2 and H3N2. These three subvarieties are seen. Continuous assortment of genetic material between subgroups, a very notable point. Why you cannot develop a continuous effective vaccine against this influenza virus? Why? Because of continuous assortment of genetic material between subtypes and formation of new strains happening. So vaccines may turn ineffective anytime. So that's a very important message to us. We should focus on the guest. Rather giving more importance on guest factor, we have to focus on the host factor. It spreads by droplets, aerosols which can land in eyes, nose or mouth of another person within 1 meter. Some interesting facts before COVID-19. If you want to visit US or some other places, you have to mandatorily take flu shots, the vaccines, and a lot of people died prior to COVID-19 unnoticingly. We were not noticing that so much people were dying in Western countries due to a simple illness called the flu. That was very curious. But when COVID-19 came, that became a very headline that a lot of people are dying every day. In every year, when the season of flu happens or it passes through the Europe and the US, a lot of people happen to die. For example, a statistics which was taken by the Center for Disease Control between October 2019 and April 2020. There are 39 billion to 56 billion flu cases was there in US, and out of them 24,000 to 64,000 flu-related deaths were reported in US up to April 2020, a period from October 2018 to April 2020. So that much deaths were happening every day. That points to the fact that the unlimited consumerism, the unlimited use of antibiotics and other medicines, highly technocentric medications, focusing more on guest factors rather than strengthening the host factors. All these were leading to such a great amount of deaths every year in such countries, even though they maintain a high culture of sanitation, hygiene, everything when compared to countries like us. In Kerala, in India, in 2018, almost 6371 cases of influenza were reported and 226 deaths were there. And in India, the pattern of influenza is commonly the H1N1. Spreads mostly by respiratory route, multiplies in cells lining the respiratory tract. Cells undergo necrosis, love away. Mucosa will be hyperemic and edematous. Pneumonia, primarily viral or secondary bacterial, may ensue and death may occur anytime. The clinical features will be onset of sudden fever, myalgia, and non-productive cough. See, a fever, myalgia, non-productive cough, all those point to simple vata kapha jwara. So how the people are dying? Because of pneumonia, which is happening in between, especially to those persons who are immunocompromised, who are having long-standing debilitating illness, who are on the support of certain medications to prolong their life. So all those people will be affected due to pneumonia, and it is very difficult to bring them back to their life, even if a virus as low in potential as influenza attack happens. So the complications will be primary influenza virus pneumonia, which is having high mortality, high fever, cough with the blood-stained expectoration, dyspnea, cyanosis. These are the clinical features. Very seriously affecting, especially for those with the prior history of myocardial infarction, COPD, or rheumatic heart disease. There is high mortality due to primary influenza virus pneumonia. Influenza pneumonia with a secondary bacterial infection, it is another type. There will be more chances of consolidation here. Bacterial pneumonia caused especially by staphylococci, streptococci, pneumococci, and Haemophilus influenzae. Also, it is also having grave prognosis for those with the debilitating illness. And there is another term called coryza. Coryza and flu is different because nasal symptoms are more in coryza, less prominently seen in influenza. Adenovirus infection creates more sore throat and pharyngitis. Another term is streptococcal pharyngitis. It is giving more sore throat, cervical adenitis, and neutrophilic leukocytosis. So if you see cervical lymphadenopathy, neutrophilic leukocytosis is seen instead of neutropenia, which is usually seen in viral infection. But it is presenting like the influenza. More chance is, if there is a sore throat, more chance is it is a streptococcal, it's a bacterial pharyngitis. So differentiating between bacterial and viral component by using this type of approach. And now I am going to deal with the Ayurvedic approach of influenza along with pneumonia, because both can be done concurrently. So community acquired pneumonia is a very huge problem where pneumonia, a patient is declared as having community acquired pneumonia if he is having pneumonia, that person is outside long-term hospitalization or within 48 hours of hospitalization. So it differentiates from a person who got pneumonia from a hospital setting. This happens to be important. Why? Because the pattern of organism which is creating a hospital acquired pneumonia is different from community acquired pneumonia. Pneumonia happens when there is a defect in pulmonary defense mechanism or a failure in pulmonary defense mechanism like mucociliary clearance, cough reflex, or immune response. If these systems will fail in patients with the long-standing pulmonary diseases, rheumatic heart diseases, previous history of myocardial infarction. So, in such cases, the failure will result in pneumonia. We hear this term pneumonia many a time now because when COVID-19 induced pneumonia is very common nowadays. So in COVID-19 cases also the situation is similar, wherein COVID-19 results in a situation, an ecosystem where the body has to defend itself by using these reflex mechanisms like a cough reflex. It has to step up the immune response of the body, or it has to enhance the mucociliary clearance so that the organisms may not gain an entry into the lower respiratory tract. But what happens is, if you are a person with a long-term medication history, especially with allopathic medicines, and also who are immunocompromised, non-exercising, obese patients who are having long-standing lifestyle-related disorders, your body is not capable of stepping up these responses, and hence the organism may gain access to the deepest recesses of the body, especially the lower respiratory tract. So in that way, pneumonia will happen. And the bacterial causes are, just for the information, I am mentioning this here: Streptococcus, Haemophilus, Mycobacterium pneumoniae, Clostridium pneumoniae, Klebsiella pneumoniae, Staphylococcus aureus. All these can cause pneumonia. Influenza virus, respiratory syncytial virus, adenovirus, parainfluenza virus cause viral pneumonia. And the fungal causes are also there. Never think that this pneumonia is a bacterial disease alone. Histoplasma, blastomyces, coccidioids, all these can result in fungal pneumonia. The usual clinical features are fever, cough with or without sputum, dyspnea, sweats, chills and rigors, chest discomfort, myalgia, headache, abdominal pain, anorexia, hemoptysis, fatigue. All these are the usual clinical features of pneumonia. And the physical findings are fever, tachycardia, tachypnea. So remember that if you are admitting a patient with such symptoms or managing a patient with such symptoms in an OPD setting, and you can see that if the patient is presenting with the tachycardia or tachypnea or arterial oxygen desaturation, you are hearing bronchial breath sounds in areas where you have to hear the normal breath sounds like vesicular breath sounds. There is an alteration of breath sound pattern. Then you can be sure that the patient is getting into pneumonia. So auscultation is a must when you manage a patient with a respiratory associated infection. Auscultation is a must. So practice auscultation very well. A lot of information is available in the net. Also, you can refresh the old clinical methods textbook. So we will be getting a good idea regarding how to catch these sounds, and that can be equated with the change in infection pattern. And the lab and imaging panel will also help you. If you go for sputum culture, you can identify the organism. Also, for us, more help is, we are not interested in finding out which organism. Instead, we want to know how the body is performing. So we are doing CBC with a differential panel, serum glucose level, electrolyte level, RFT, LFT. See, while doing LFT, if we see that SGOT, SGPT is rising very fast, one thing is very sure, that Dhatu Bhagam is happening in the liver. Liver cells are getting destroyed. The kidney cells are getting destroyed. Urea, creatinine values are increasing. Kleda bhava is increasing in the body. So, when taking an X-ray, chest X-ray, pulmonary opacity or chest CT finding showing a pulmonary opacity ranging from patchy airspace opacities to consolidations, pleural effusions or cavitations. Another thing comes to our mind. There is an appearance of this patient with the Shadagasa, wherein in our textbook, Shadagasa is caused due to Yuthadehi Sahasehi. But here, the micro trauma is happened to our chest due to an infection. That can also be taken in the same way as that of Shadagasa. There, Acharya says that Kramad Viryam Ruchi Paktir Balam Varnascha Hiyade. The patient is getting slowly deteriorated and succumbing to death. So such pattern, Shinasya Sasrang Mutratvam, Syacha Prishta Kadigraha, Sasrang Mutratvam, correlate it with the RFT pattern you might be seeing. So Kshadagasa comes into forefront. The Jwara was there, Kasa was there. Slowly the Kasa progresses from Vadi Kasa slowly into the Kshadagasa pattern. And when Kshadagasa comes into forefront, it can slowly deteriorate the status and it can lead to death of the patient. So, such an approach shall be kept in our mind while we manage people with respiratory infections. And another type of pneumonia which we used to hear is nosocomial pneumonia, which is of pre-type, that is HAP, hospital acquired pneumonia, which is when the patient is getting infected from a hospital. Ventilator associated pneumonia, it is due to different species, which is due to certain procedures like endotracheal intubation or ventilator, which is associated with the body, and healthcare associated pneumonia, which happens to some persons who are in the community but who is associated with the healthcare, especially the persons who are in contact with the patients who is lying inside an ICU. They can get this HCAP. See, the mortality rate is 20 to 50% in hospital acquired pneumonia. Another theory which is coming around this HCAP is the long-term use of antacids. The PPA, that is proton pump inhibitors, H2 receptor antagonist, all these may change the gastric microbial pattern. So there will be gram-negative microbial overgrowth and tracheobronchial colonization may happen that result in HCAP. So, if a patient who will be coming to you with the signs of pneumonia, it is necessarily to question the drug pattern of that particular patient. If he or she has been advised with such medicines which are having such property. This is a new theory, that is elevation in gastric pH leading to pattern of change in microbial growth, leading to tracheobronchial colonization and onset of pneumonia. This pneumonia may turn fatal to a very elderly person. So we have to step down those medicines, add our medicines to reduce which is having an antacid property, or reduce the Samapitta and thus help the patient. So, while dealing with such cases, another thing also comes to our mind. Urastaha kurude swasam amashaya samudbhavam. So, all these entities, Jwara or Kasa, Swasa, all these having an inherent connection with the amashaya. So, here also in amashayam something is happening. The response we are seeing in Uras. So, the connection between Uras and amashayam is very prominent when we deal with an HCAP, hospital or healthcare associated pneumonia. And then comes the third one is anaerobic pneumonia. There is history of aspiration. This anaerobic pneumonia is otherwise known as aspiration pneumonia. This is very important when we go for palliative care patient. Getting into a palliative care. So we will be visiting a palliative care facility or to a house where a person is lying under palliative care supervision. The patient may be depressed level of consciousness, may be having repeated seizures. may a patient under general anesthesia, impaired deglutition, those with nasogastric tubes, or a patient who is cachectic, long-term crippled into the bed, when we visit them, sometimes they will be telling us an insidious onset of symptoms. Lung abscess may happen when medical attention is sought. So, a dramatic onset of symptom may happen. Gradually, the patient will be developing pneumonia. The essential thing is that we have to ensure that for such patients, feeding should happen in a sitting position only, so that a level of aspiration can be prevented. Another thing is maintenance of oral hygiene. This happens when the patient is having a very bad oral hygiene with lot of anaerobic organism residing in the mouth, and there is a very chance of those organisms shifting into the lung cavity because of aspiration. And the patient being a bedridden case, he is having fever, attending fever along with the weight loss, malaise, etc. Several or anaerobic species like Fusobacterium, Streptococcus, Prevotella, Bacteroides, all these may be the cause of this pneumonia. And there will be cough with the foul-smelling purulent sputum. So the foul-smelling sputum is pointing towards the presence of anaerobic bacteria that may cause an empyema. Empyema means the presence of pus in the pleural cavity, or that can create a well-defined lung abscess if you take a chest X-ray. So, a well-defined lung abscess or an empyema, that all point towards an aspiration pneumonia. So, this is very common in case of palliative care settings. Previously, I have once read about a practice which was prevalent in Tamil Nadu, wherein a patient who is long time bedridden, that patient having no hope of recovering back to life, then the people in the house will decide together in one particular day, they will give a very good oil bath to the patient, especially to the head and also to the entire body, and place the patient outside in the sun for some time, and then giving him a head bath, and likewise with the cold water. The practice was called Tadil Kutu. And at that time, after 2 or 3 days, the patient will start cough, productive cough, purulent sputum, fever, and gradually the patient may succumb to pneumonia. This has been banned by the court. I think the Honorable High Court has banned this practice. So this is a process. And also, we might have heard of certain very respectful public figures who have been admitted to the hospitals, ICUs, for a long time due to different diseases, especially due to some other systemic disorders, due to gastrointestinal illness or neurological illness. Later, the death reports or the press reports by the hospital will be telling that the patient have succumbed, the patient have developed a pneumonia for 2 days. He is in active interventions. Yet, after 2 or 3 days, the patient was found to be succumbing to life. So, think about the community acute pneumonia, the hospital acute pneumonia, nosocomial infections, all this leading to the ending of life due to pneumonia. So, what I want to say that in our textbook, Acharya was telling that Sarvebi roga nashaya natu evam shikragarina. Natu evam shikragarina, like Shwasa and Kasa, Shwasa and Hitma. So, Shwasa and Hitma were given a designation that they are Mrityugale Krudalayo. They will make the body of the patient their abode at the time of his death. So such type of Shwasa which is having. So one of the characteristic feature of this pneumonia is dyspnea. So the evolution of dyspnea along with the fever, such factors will point to an imminent death of the patient. So we have to manage such patients in an aggressive mode. Ayurvedic approach of influenza and pneumonia. I am not going to speak about some clinical entities like Shosanagajwara, some terms Shosanagam or Kante Kubjam, etc. Because even though such entities have been named, have been detailedly described, the medicines, the selection of medicines were dependent upon the doshic status as well as the avastha of the patient. So it starts typically as a Vada Kapajura, proceeds as such an end in majority. That means it can recover back if we are giving proper care. And beware of the complicating type when it proceeds to Sanibadi Gajara. Resist dosha paga due to inherent weakness of Agni. Dhadu paga ensues, affection of Hridaya Marma and Durus succumbs. Here, we can add one more point that the Samprapti may proceed from the Jwara, then it may proceed into Swasa, it may proceed into Kasa, especially Kshada Kasa. I may tell that in the case of an aspiration pneumonia, all these Samprapti work under the framework of Rajyakshma. Think about the Ekadasi Rupa of Rajyakshma. Pinasa, Swasa, Kasa, Amsa, Murtha, Swaradijo, Aruchi. Urtvam, Vrithamsa Samshoshavadha, Chardischa Kostage, Tiyakste, Parsharu, Doshe, Sandige, Pavadi Jaraha, Yubani, Ekadasedani, Jayande, Rajyakshmina. So, the Ekadasi Rupa of Rajyakshma scaffolds all into one plane. That means when Rajyakshma Ekadasi Rupa happens, it includes the Jara Samprapti, it includes the Kshadagasa Samprapti, everything. So we have to operate this type of influenza, pneumonia, etc. by becoming more resourceful. In that way, we have to select our medicines from the context of Jwara, from the context of Kshadakasa, from the context of Rajyakshma, and bring the patient back to life. Also, we have to focus on the Hridaya Marma Abhigadam, Uro Abhigadam, etc. So, what all factors that can protect that particular areas that can also be instituted. Different possibilities exist. Mild fever, myalgia, loss of appetite, productive cough, dyspnea, all these can be managed by giving Vyakriyadi Kashayam, Dashamula Gadatriyadi Panam, and for assisting the fast recovery, also for expectoration, for bronchodilation, in order to give expectoration so that the secretions are not trapped inside the respiratory tract. You can give Acharishtam Kanagasavam. Also, in such cases where there is a lower respiratory tract infection with the purulent sputum, foul-smelling sputum, the patient is having dyspnea, heaviness of chest, etc., mild fever is there. Never hesitate to give Surya Prabha Guliga and Lakshmi Vilasarasam. And if the patient is having intermittent dyspneic episodes where the patient is having different difficulty, very severe difficulty to breathe, Swasanandam Guliga is another option along with the Tambula Swarasa or ginger juice can be given. We used to give vaporizing once or twice a day to the patient along with placing hot water bag on the chest and in the back of the patient, chest and back of the patient after placing a towel. So on the towel, hot water bag is applied. So that will give a dilation of the respiratory tubes and more expectoration. If the situation is worsening, you have to change your strategies. You have to step up the aggressiveness in which you are dealing the patient. Fever, expectoration, dyspnea, heaviness of chest, sometimes hemoptysis, the patient becoming very weak. One suggestion I will give, I will read from the last, Lajapeya. Lajapeya Sugajara Shundi Dhaniga Pupili. This is a Peya Yoga which is mentioned in Ashtanga Hridaya. And even in some textbooks like Sarvaroga Chikitsa Ratnam or Vaidya Manorama or Chikitsa Kramam likewise, different Peya Yogas are mentioned which can suit the clinical condition. Also, Ashtanga Hridayam, there is Vyakri Gokshida Sadhita Peya is mentioned. If there is hemoptysis, if there is chest infection. Dashamula Sadhita Peya is another option. Dashamula Sadhita Peya. So, in the Peya, instead of using rice, you can use this lajam. Laja. I don't know the exact translation of Laja. So the Laja Peya, it is easily digestive and it should be processed with the Shundi, Daniga and Pipili. That will aid digestion. In many palliative care cases, I have used this Laja Peya, and especially those patients who are in a level of Raja Ekshma where the digestion of the food is a big problem. Laja Peya happens to be a source of rescue, wherein when the Laja Peya is started, it happens to extend the life of the patient. Patient can eat in small quantities, multiple feeding times. Always keep the patient in a sitting position and give or raise the bed of the patient and then give the feedings. And add Kasturi Kalparasayanam to the Vasharishtam Kanagasavam formulation and give it thrice a day. Daru Nagaradi Kashayam is another option. Now we can see there is Dashamula Gadatrayadi Kashayam, Vyakradi Kashayam, there is Belajiragadi Kashayam, there is Elaganadi Kashayam, and there is Daru Nagaradi Kashayam. Daru Nagaradi Kashayam, the indication states that Mrityu Kalpam Jaram Jayed. That means those patients who is destined to die because of this particular illness may be brought back to life by giving this particular kashayam. So it is very potent. I have noted in certain cases and also heard the experiences of some of my teachers, especially Dr. B.K.V. Balakrishnan sir in Pariyaram Ayurveda Medical College, where he uses this Daru Nagaradi Kashayam for treating pediatric pneumonia. So it is very effective. That can be given in multiple doses. Yoshadi Vadagam is another option. Also, there are another kashayams like Bhargyadi Kashayam, Pathya Katphaladi Kashayam that can be employed. Rasnadi Churnam can be put as a talam for reducing the temperature. And another formulations like Mukka Mukkadagadi Guliga, Gorojanadi Guliga, etc. And Chukkundippaliyadi Guliga. These three can be employed in addition to the drugs mentioned here to reduce the chest infection, to bring back the fever or the temperature down to the normal, and to bring back the life of the patient. Anyway, the cornerstone is to maintain the belem of the patient. If you are pumping in lot of medications to the patient, and day by day if the patient is weakening, there is no point in managing the patient. The patient may succumb soon. So maintain the belem of the patient by adequately giving the drugs like the peya, and then give very targeted therapy to the patient by using these medications. And once the patient recovers from this, if there is severe dry cough, mostly if there is a viral pneumonia, there is a post-viral hypersensitivity of respiratory mucosa. So there will be, even just by putting a fan, they will start to have a very dry cough, and attending chest pain will be there. Crepitation, span, chest fields may be heard. And in such cases, Elaganadi Kashayam and Lakshadi Churnam is a very good option. Elaganadi, Lakshadi Churnam means Laksha Siddha Madhuga Jiraga Churnam. It is the Prakshepam of Elaganadi Kashayam that can reduce the severe dry cough, chest pain, etc. Agastya Rasayanam, if made classical, is very good for this stage. Classical Agastya Rasayanam means Haridagi is not ground into the lehya. Instead, it will be put as such. And the patient has to take 2 haridagi along with some lehya for one time. So, after recovery, the patient should be treated like this to bring back the lost rogi bela of the patient. And before winding up my class, my take-home message is this. In every fever, I have just gone through these different types of fevers, just peripherally told you about certain protocols which are drawn from those big therapeutic treasure troves. There is a lot more to take up. See, while dealing with this Shadagasa, I think, and also in Swasa, there are Dhumapana yogas. Dhumavartis can be made. Manasila Dhumavarti is there. Some good Dhumavartis are there that can be employed. Then other therapeutic options like if the patient is having sufficient belem, some Sadhyo Vamanam can be done. तत्र उत्कृष्टे समुत्कृष्टे कपप्राये जले मले स हृल्लास प्रसेग अन्नद्वेष कास विषूजिगे सद्योपुक्त शिवोद्गारे ज्वरे सामे विशेषता वमनं वमनार्हस्य. It is told rightly in Jwaram. So such procedures will wonderfully recover the patient back. And there is a practice of giving some svedana in the chest in cases where there is a lot of pus getting, the sputum getting trapped, yet not coming out. In ancient Kerala textbooks, such practices of giving tavidu kiri, the kiri of the bark of rice, the husk of rice, is given. And I have heard a lot of experiences from senior Vaidyas who brought back the patient to life by giving this svedana of tavidu kiri in the chest. So such when reading through the textbook, we can see that the management is gradually getting more aggressive when you are dealing with a Sanyabadija Jara, especially when Dhadupagha is happening. So, in every fever, assess Bela Samprapti of Roga always. Hetwadi Karsnya Avayaver Bela Bela Vishesham. That means you have to think right from the Hedu. If you are hearing about the Hedu, which is an Agandu Hedu, which is a particular organism which is devastating effect, you can think that the Bela Samprapti is very powerful. Hedu, Rupa, Pururupa, all those things are standing in a highly exacerbated position. So think that the Bela Samprapti of Yoga is very powerful. The Bela is very powerful. Yoga Bela is very powerful. And then consider the Rogi Bela. Assess the Rogi Bela. We want to think about the different Sampraptis operating in the patient at a time. How the patient is like at this particular moment, how he was there 5 years back, what was the change in the body habitus, how his build has changed, how he was crippled to bed, what is the current status of his digestion, what is his acne, what is the status of Padani Romana. So thinking of all these factors, we can arrive at a judgment. And for specific mentioning, you can take the Dashavida Parisha of Charaga. So you will be getting a very precise measurement of what is the Yogi Bela of the patient. Compared to whether Roga Bela is more than Yogi Bela, you have to step up those strategies which can work out, which can give more focus to Yogi Bela, which can support Yogi Bela more, so that the patient can suffer or the patient can bear with this particular disease. Many a time, the illness, the disease, the jara kills the patient not because of its power, because of the weakness of the Yogi Balam. So maintaining Yogi Balam by using suitable Peya is very, very important. And in Malayalam textbooks, there are a lot of different Peya are mentioned. Also in Ashtanga Sangram, you can get different varieties of Peya that can be used. In Charaga Samhita is also richly mentioned. Peya is very much mentioned for preserving the Yogi Bela. Be careful to sense the Dhadu Pagam. See, when you get an electrolyte imbalance, when you see a patient who is suddenly having change in the mental attitude, when you see a patient who is having restlessness, when you see a patient with the sudden onset of loss of sleep, sudden reddishness of eyes, sudden change in the perception, the orientation, all these will point towards the Dhadu Paga. The sloga like Nidra Nasho, Hridistampo, Vishtampo, Gaurava, Aruti, Ariji, Aratir Belahanischa Dhaduna Paga Lakshana. A patient who was walking in the evening, suddenly getting crippled to bed by the night. That is onset of Dhadu Paga. Also use some very meticulous diagnostic modalities. For example, what we have used in the case of COVID-19, like a D-dimer, ferritin, the CRP, or such indicators which are pointing directly towards Dhadu Bhagam, like SGOT, SGPT. So all those factors may draw your attention towards the ensuing Dhadu Bhagam, and you can start therapies which can stop the fast progression of illness. reduce the Dhatu Bhagam and promote the Dosha Bhagam. So the duty of physician is to regulate the Bhaga process well. So we are managing this case. We have to allow the body to continue with the Bhaga process. But the Dosha Bhaga should happen. Dhatu Bhaga should not happen. Agni should be strengthened to create the metabolization of doshas, not of the dhadus in which it now resides. And always maintain yogi balam by payadi krama. Be prepared always. Prepared in the sense that we have to continuously go through the literature. Reading Jwara Chikitsa from Charagam, Susrudam, Ashtanga Sangraham, Ashtanga Hridayam. Then going through the different textbooks like Bhaishya Ratnavali, Yoga Ratnagaram, Bhava Prakasam, Kalyana Karagam. Then the new textbooks like Vangasenam, Basavarajyam, all these give you wonderful wealth of information. Nothing to say about those texts like Rasa Yoga Sagaram, Rasa Tarangani, Rasa Ratna Samuchayam, etc., which will focus, which will sharpen your prescription. So always be prepared and always read the clinical entities, about the different clinical entities from the modern clinical textbook, so that you stay prepared to advise the patient regarding prevention, prophylaxis, management, and post-recovery care. For example, in the case of post-COVID, the post-recovery is very, very needed. So all those areas need to be updated, and the effort which we need to put in is much more than our allopathy counterparts. So what I finally want to say that once you complete reading all these things, surely you will be inspired to treat not only Jwara, but also all other entities in the textbooks. So let me close this session by giving my humble dedication to Professor Dr. Prakash Mangelasiri sir, who departed from away from us, who taught me Jwara Chikitsa when I was a final year BAMS student. So this presentation I am placing in his lotus feet, and also I wish you all the best in your further treatment. Let you manage all the diseases well prepared. Always increase the stuff in your hand and apply it in clinic, so that new information and can be developed and that can be shared for the betterment of all the physicians and all the patients. Thank you all for the very patient hearing. Thank you.
Thank you, sir. It was really an eye-opening and an enlightening session. Okay. Okay, participants, if you have any doubt, you can ask directly. Okay, you can unmute and ask. Okay.
Dr. Rahul, it was beautiful presentation, and I enjoyed every part of what you said on the Jwara Chikitsa. Thank you so much. And I have two things. First, all the beautiful shlokas you have quoted, can we get a reference? Because it is so big, such a vast subject in Jwara. Could you quote us somewhere? Not now. Later on, could you send us a message on all the quotes you have for us?
Yeah, sure. I will share it with the organizers. I will give the references of all those slogas which I have used it here.
Yes, sure. Thank you, sir.
Sure.
Thank you. And the second one was I'm very fascinated with the idea of Dhatu Paka and how you have mentioned the serum glucose and electrolytes and RFT, LFT as a reference to understand the Dhatu Paka. Is there a way to understand, like an indication of where the Dhatu Paka is happening to these particular testings which you have mentioned? And this is a beautiful way to understand the modern medicine and to understand the Ayurveda. If you can explain a little bit on that, sir.
Dhatu Paga is actually the Pagam is a very basic concept in Ayurveda, wherein some derangement happened with Agni. It resulted in the formation of Amam. So Sama dosha come into existence. And the Agni is trying to create the Pagam of the Samadosha. And we are actually assisting Agni to create Pajana. That means If you are giving Vetumaran Guliga, this Vetumaran Guliga is going to assist the Agni to increase its Tikshna Guna so that it can create Paga of Ama from the doshas. So, when the Agni is not so strong and our medicines are not giving its benefit to the Agni, what will happen? Agni will try to create the Paga of the dosha, but it is incapable of doing that. And as the Agni now resides in the Shakha in contact with Dhatu, it will be gradually destroying the Dhatus. This happens especially for those patients who are having already reduced Dhadusara. So, as you have asked, how you can point the Dhatu Paga to a particular area. That can be done by suitably reading the two materials together. For example, somebody coming to us with an angina or some chest pain, and they are telling that I am suspecting some cardiac attack going on. What to do, doctor? So in that case, many a time we will take an ECG, and also we will be sending the patient to take some biochemical test like troponin. So if the troponin value was found to be elevated, we will say that I'm not telling any textual material. Instead, I am telling that troponin happens to be an indicator of Dhatu Pagam happening at the level of cardiac tissue. Similarly, a patient is having jaundice. He is having ascites coming to us. We are getting a report that the patient is having cirrhosis. So the entire architecture of liver is destroyed. So if you take SGOT and SGPT levels, it is found to be very high. We say that there is accelerated destruction of liver tissue happening. So in that sense, the Dhatu Paga is happening focused on the liver tissue. So in that case, the advantage is that we can focus our medicines specifically to that particular area. So in that way, you can find out the markers which are pointing towards cell destruction in particular areas, in different areas, and also to a certain extent those tumor markers like CEA or CA 19.9 or CA 125 that points to rapid destructions which is happening in certain particular areas due to tumors. So in that way you can equate. I don't think it is a perfect mechanism. I think the Vaidyas of previous generation were capable of detecting Dhatu Pagam happening in some part of the body with multiple mechanisms like Nadi Pariksha, like by doing meticulous examination of patients' surface part of the body. They can find out, and also the location of Vidriti. There are beautiful descriptions of the location of Andar Vidrati, finding out the location of Andar Vidrati by using clinical features. Nabhyam hitma bhavet vasto mutram kritsrena pudija. This is mentioned in Ashtanga Hridaya. In ancient days when there were no imaging facilities, one need to find out a Vidrati which is happening inside, which is getting rapidly in Paga Avastha, which is situated in Nabhi Pradesha. We can identify it by using a clinical sign called a Hitma. So in that way, there are different signs mentioned in Vidrati Nidana chapter also, wherein Dhatu Paga at different localities can be identified by using certain signs. As we are not seeing not so much cases, as well as we are not trained to develop our inner eye, because I think that we should stand with a reputed clinician for long years to get trained our eyes properly to see that particular sign and identify that some Dhatu Paga is happening that level. We can easily pick it up even without using this biochemical test. I sincerely feel that the use of these biochemical tests as well as the imaging facilities is a beneficial for us if we people are not so experienced, or we are not fortunate enough to receive a training from a great clinician to stand with him, to see a lot of cases, and then identify these clinical features. Actually, by continuously going through Ayurvedic classics and trying to see those classics in front of us in our OPD and IPD, we are inherently training our eyes so that our dependency on these biochemical tests and imaging will be reduced day by day. I feel so, madam.
Thank you so much. Yes, absolutely.
Thank you, madam.
Okay, sir. Can I take one question from the chat box?
Yeah.
Okay. Okay, what is the